بس اشكر رؤساء المؤتمر واخص بالشكر الدكتور حنان والدكتور حافظ على تحت الفرصه اللطيفه دي. Plasma exchange for critical age children with autoimmune hemolytic anemia. Pediatric autoimmune hemolytic anemia presents a variable severity. An acute presentation is frequently life-threatening and fast progressive disease which needs rapid intervention and specific treatment. The annual incidence for pediatrics is very rare. It is approximately 0.8 per 100,000 individuals under 18 years old. Usually it's associated with other immune disorders in 53% of cases. It's usually a fatal disease due to either its acuity and being refractory to usual treatments. The most common forms are the word-reactive autoimmune antibodies. The other forms are called agglutinin disease and the Brucella called hemoglobinuria, and in some small subset of patients there is mixed autoimmune hemolytic anemia. The cold agglutinin disease usually have a self-limited and short duration course, while warm reactive autoantibodies autoimmune hemolytic anemia tend to have a chronic course and is not expected to subside without treatment. The first usual line of therapy starts with glucocorticoids, intravenous methylprednisolone, in up to 30 mg per kg per day dose. The goals of initiation of treatment is to decrease the hemolysis, to stabilize hemoglobin, and to increase the tolerability for back red blood cell transfusion. The steroid efficacy is response rate is up to 80%, and the response appears within 2 to 3 days after initiation. In 2002, there was the first reported case report about the use of PE, of plasma exchange, in severe cases of autoimmune hemolytic anemia, reported by Roy Berman and Glader. And since then, there is a separate case report about this topic. For the best of our knowledge, we are the first to highlight the role and outcome of PE in a large cohort of autoimmune hemolytic anemia patients, intractable to management by mega doses of steroids. Our study is a descriptive study, including all patients admitted to the critical care unit of Children's Hospital Cairo University in Munira, who underwent plasma exchange for intractable autoimmune hemolytic anemia resistant to steroids. We included the patients 1 month old to 14 years with severe autoimmune hemolytic anemia requiring transfusion, presenting with actual or impending system failure and have a failure response to mega doses of steroids and or IVIG before PQ admission. The technique we adopted is by using the membrane plasma separation through the PlasmaFlex machine. Filters used was TPE 1000 or 2000 according to the patient's weight. The volume used was about 40 to 50 ml per kg of 5% albumin and the least mismatched red blood cells during the session. In some cases, we have to transfuse mismatched blood grade 3 or grade 4. This was the least mismatched packed blood cells available for those patients. Usually we start with 1.5 exchange, then the further sessions, if needed, are made by single plasma exchange, and the number of sessions are tailored for each patient. We have enrolled 19 patients who had plasma exchange for intractable severe steroid non-responsive autoimmune hemolytic anemia from the years 2017 till now. There are some patients before this duration but lacking full medical records. 11 of our patients showed associated comorbidities. 3 have event syndrome, 1 lupus patient, 2 thalassemia patients, 3 immunodeficiency patients, and 1 hyperammonemia and 1 inflammatory bowel disease. All our patients have received pulse steroids to get matched back red blood cells with unsuccessful results. The mean age of our patients was 6.3 years, 10 males, 9 females. The mean weight was 21 kilos. 3 of our patients needed mechanical ventilation. Mean hemoglobin upon admission was 5.2 gram per deciliter. 9 of our patients had COMPS test before blood transfusion. 7 of them were having a positive COMPS test, and the mean reticulocyte count was 13.5%. Unfortunately, 42% of our patients give a history of receiving pre-PQ admission, IVIG, to control their hemolysis with unsuccessful results. The mean number of sessions needed in our patients was 2.4 sessions. The minimum number was 1 in many patients, and the maximum was 7 in 1 patient. The mean PQ stay was around 17 days. Hemoglobin on discharge was about 10 grams per deciliter. A small subset of our patients needed further immunotherapy, as one patient needed sirolimus, one rituximab, three patients needed Silsat, and 2 patients needed azacitidine. Favorable outcome was achieved in 17 of our patients with mortality in only 2 patients. 5 of our patients unfortunately showed recurrence of the disease. Finally, we can conclude that PE may be used as a successful therapy in severe, acute, life-threatening autoimmune hemolytic anemia not responding to steroids and or with difficulty to provide a well-matched background blood cells for transfusion. Thank you.